the decompression from anterior. And also he has underwent another surgery from posterior less than 1 year ago. And the posterior operation didn't bring some benefits. So for this patient, we chose the ACF the surgery. Here is the video. We decided to perform the ACF of C3 to 4, and we will
We start in 25 minutes. And welcome. Yeah, you don't have to come in the panel. You can still participate. And you can ask questions by texting also. Okay, Hassan and Trin. So don't worry, you don't have to come in. Hey, Narayan, can you hear me and see me?
Yeah, I can hear you and see you. Good evening, John. How are you?
Good. I'm glad you came early because I want to straighten this out.
Yeah,
Are you from Jabalpur or Bengaluru?
Jabalpur. I was
Okay.
born in Bangalore, but then I stay in Jabalpur. I am working.
You're the same hospital as Dr. Yadav?
Yeah, though, all four are from the same hospital. Jitin, as well as Sharendra. We are all from, and Dattaraj is from AIMS, Delhi.
You know, I don't usually wear a tie.
Yeah, yeah. No.
This is the only time all week I wear a tie.
Yeah, no, more than me, you are working. I think, you're there from morning till evening, helping everyone.
You wear scrubs most of the day, right?
Yeah, I'm the professor now, Professor HOD.
Yeah. You just run around the hospital in scrubs, right?
Yeah.
That's very convenient. That's very nice.
Yeah.
I mean, I know how comfortable it is. Yeah, it's very comfortable.
We admire you. You're doing a great service.
Here's Dr. Yadav. He's early.
Here, Dr. Yadav must be coming.
Oh,
Sir, good evening, sir. Oh, yes, to unmute. Good evening, sir.
Good evening, how you doing?
Good evening, sir. Good evening, Professor John, sir. Good evening, Professor Swami.
Sir.
And the other people have also joined?
No, sir, not yet.
Okay. So no problem. I think they will join soon.
Sir,
You inform Dr.
yes, sir. That's right.
Datta.
Nice.
Okay. I'll
And
call.
from-
Okay, I'll be back, Dr. Yadav. I'll be back, okay?
Sir. So I think Professor Swami, I just want to see
Sir,
my presentation. I think if
share screen try. I think John only has to do it, but then
Yeah, you wanna go over it
It is
now?
possible.
We'll check it out. You got any videos or something?
I think it's possible, I'll see whether the video is running or not. The sequence of events will be same.
okay, sir.
Okay,
Yeah. So I'll just see in case my so slides are okay.
yeah,
Yes, sir.
This is this is a video how to do endoscopic surgery, teaching exercises.
okay. No sound, right?
And no sound. He'll be speaking.
No, I'll be speaking.
Okay, that's fine. That's
There is no
better.
sound. Yeah. So the quality is
Coming
all.
fine, sir. It's coming fine.
Yeah, I just want to teach them
No, it's
how.
good, it's good quality. Looks good to me. What do you think, Narayan?
Yeah, it's fine. Absolutely fine.
Yeah. Then this is only for teaching purpose. There is no colored video or anything. So that is all. I think it's fine.
Yep,
This
looks
is
good.
the only. So after that, we have one or two more videos. The slides are also okay.
Yes, sir.
Yeah. Mhm. Okay, yeah.
I think Professor John, she is a film star, Madhuri Dixit, Indian film star, very beautiful lady.
Oh, you must be knowing she was in US.
Okay, so I just want to say that if you want to, I mean, if you see overview, then you can diagnose, but not by just seeing the eyes. So this is what the limitation is. So people should feel a little bit of interested. What about this video?
It's coming fine.
Okay,
Fine.
so should be okay. So I'll just see the another one. Chronic SDS. So these are 3 videos.
Yes, sir.
Okay. So excellent. So that's all. Right. So I stop share and then I'll call these people.
Yes, sir.
Dr. Datta, what he's doing. And you also inform this fellow.
Yes, sir. Yes, sir.
The number you're trying to access has been temporarily suspended.
Jitin, he's joining, Dr. Datta is joining. I'll call Jitin and then Dr. Ratri has joined. Jitin also has joined. Okay, so no problem. Yeah, you have joined. Okay, okay, good. Okay, bye.
Good evening, sir.
Good evening, Salen. Good evening, Jitin.
Good evening, sir.
So I think we have the same sequence that Professor, John sir will introduce Professor Swami, and then he'll introduce us, 3-4 of us. Then I'll start, and after that, you can, after finishing this, you can invite comments of panelists. Okay, Swami Sahib.
Yes, sir.
And then we will answer the queries if there are any. Okay. So, when still, so I can just see what, I think there are 8-9 minutes. So I'll go through the slides and
Okay, we start in 5 minutes. Good day, Dr. Jitin.
Good evening, John, sir.
How are you?
Welcome Datta, welcome, good evening. Welcome Jitin,
Good evening, sir.
welcome Shailendra.
Oh, I'm sorry, that's the YouTube. That's the YouTube delay. Saying hello twice.
Yeah, good evening, everyone.
Good evening, good evening, good evening.
Sir, good evening.
Uh-oh.
Good evening, sir.
All right, he's violating the dress code. I don't know what to do.
Yeah, Datta Raj,
Next week.
next week.
Next week.
Good evening, everyone. Good evening, Joyce.
I'll be like a stern teacher that is
Yeah, I know. I know.
compassionate. Dr. Shailendra, good day.
Good evening, Dr. John.
The Arun, is he on the panel? Arun Agrawal? No. So all the panelists are here, Narayan?
Yeah, all are in now.
Oh, good. Okay,
Yeah, but under 3 minutes, you can start after 3
Right.
minutes.
right. Welcome, Harshad. Do you have your camera working today?
Yeah, Dr. Ashad Parikh is there already.
Yes,
Yeah,
we're
hi, Dr. Narayan.
good.
How are
Good
you?
evening, sir. Good evening, sir.
Hi, John. Yeah, good evening.
Are you home, Harshad?
Yeah, I'm at home. Yes.
Okay.
Yeah.
We also have Dr. Kudeshwaran.
Welcome.
Yeah, welcome, Dr. Kudeshwaran.
Yes, sir. Good evening. Yes, sir. Good evening. Good evening, Dr. John. Good evening, Jitan. Good evening, Dr. Rathre.
Good evening, sir.
Okay, 2 minutes. Okay, Dr. Yadav, are you there? Dr. Yadav, are you there?
Yes, sir. I think we can,
Okay,
yeah.
yeah, you ready to start? Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett with the following episode of the neuroendoscopy series by Dr. Yadav from India. And we're going to have basically Narayan Swami, who's a neurosurgeon from Jabalpur, moderate the proceedings. Welcome, Narayan. It's all yours.
Thank you. Thank you. Thank you, everybody. Welcome, everybody. Good evening to everyone. In this part of India, it's good evening now, and good morning, Dr. John. Well, we are continuing with Professor Yadav. You all know Professor Yadav. Professor Yadav has been the founder member of the Indian Neuroendoscopic Society. He has taught more than 850 candidates, and he's the one who has prepared all of us to introduce to the neuroendoscopy, and then further he has made us advance in the neuroscopy. He has written various chapters. He has given a lot of workshops. He has written so many papers which have got more than 10,000 citations, and he's well known, and he's got lifetime achievement for this. And he's, as you all know, he's the president of NSI. He's the past president of Neuroendoscopy Society of India. Well, if I keep continuing, probably he has got so many achievements. Thank you, sir. Thank you. Thank you. Today he would be speaking about the very fundamentals of endoscopy and the basics, how exactly to learn endoscopy, starting from single chip camera to advancing into 3-chip camera, how exactly one should go and do it in the skill lab, and then further extrapolate it into the surgical aspects. And we are also thankful to the cream of the panelists. We are joined today by Dr. Dattaraj, who is an enthusiastic neurosurgeon who can do every possible surgery, including extended endonasal neuroscopy from All India Institute of Medical Science. Welcome, Dr. Dattaraj. And we also have two good enthusiastic neurosurgeons, Dr. Shailendra Ratre and Dr. Jitin Bajaj, who are exemplary by themselves. And Dr. Jitin, he also does epilepsy surgery, and then through the endoscope, he has done endoscopic hemispherotomy, and the results are very good about it. And not wasting most time, I invite Dr. Yadav to continue with the lecture, sir. Sir, Professor Yadav.
Thank you, Professor Swami, for introduction, and I'm grateful to John sir for giving this opportunity to present neuroendoscopy series. I'm also thankful to all the panelists, Dr. Datta, Dr. Ratre, Dr. Jitin, and all my seniors and friends for viewing this endoscopic series. Today I'll be discussing the basics of how to learn neuroendoscopic skills. This could be mainly useful for the beginner, but I think even for some of the people who are doing surgery. Are you able to see my screen? No.
Sorry about that. I'm sorry about that. Okay, let me just completely move that person out. I'm sorry about that. They keep coming back. Hold on.
Somebody hacked it.
Yeah,
Yeah,
somebody hacked it. I'm
yeah,
sorry about that.
somebody
Let me
hacked it.
remove them completely.
Yeah.
somebody hacked
See
it
this?
and they are putting some
They
bugs
hacked-
and
Yeah. Some nonsense.
Mhm. Okay, I think I got them all. Okay, I'm sorry, Dr. Yadav. Continue. We'll edit all that out.
but you are mute.
Okay.
Yeah, something went.
Yeah, well, I think I cleaned it up.
It was
We should
hacked,
be
sir.
okay. We should be
Somebody
okay.
came in without permission.
Okay, so I think I can
Yes, sir.
now share again and then.
Yes.
Okay, okay. So is that okay now? Are you able to see my screen?
Yes, sir. Yes, sir.
Yes.
Okay. So thank you very much for giving me this opportunity, and thanks to all the panelists and the viewers and my seniors for encouraging me to do something in the endoscopy. So we all know that neuroendoscopy has many advantages, including better visualization. Although neuroendoscopy has many surgical indication now as standalone or as an adjunct to microscope, it is surprising that despite of great advantage of better visualization, you can see very well better than microscope, but still it is not very commonly practiced by most neurosurgeons, and we need to see what are the reasons. The possible reasons could be the lack of facilities in some part, because unfortunately the instruments are costly, and partly it could be because of the steep learning curve, which I think it is not difficult. So therefore, today I am aiming to present something to decrease this learning curve in endoscopic surgery, especially for younger neurosurgeon or for those who want to learn endoscopic surgery. One need to know the limitations. So we all know that there are advantages, but there are limitations, and those limitations are big, and you need to overcome those limitations to learn the endoscopic surgery. So I'll be mainly discussing the limitations and how you can overcome those limitations so that you can learn endoscopic neurosurgery, which I think is very important. For me, I have already discussed that there are a lot of indication for endoscopic surgery, pure endoscopic surgery, and these indications are increasing day by day. So we can do ETV for hydrocephalus, lumbar disc, or LCS, or disc preserving surgery in the cervical spine, disc prolapse, or the posterior approach when the lesion the compression extends up to 6 level, which we'll be discussing later on. In another this thing, partial corpectomy when there are multiple level compression from anterior side, intraventricular bleed with hydrocephalus, hypertensive bleed, deep-seated tumors, endoscopic assisted microsurgery, the pituitary adenoma, almost all of them can be removed now using endoscope, and transnasal approach. Transnasal approach for craniopharyngioma, microvascular decompression for 5th and 7th cranial nerve. You can do biopsy or take out the tumor of the posterior third ventricle tumor. You can do transcervical approach for atlantoaxial dislocation. Both decompression and fusion can be done. And you can also do transoral surgery for AD or basilar invasion. Both decompression and fusion can be done. CSF rhinorrhea, intradural tumor, brain abscess, arachnoid cyst, foramen magnum decompression for ACM, chronic subdural hematoma, and septum pellucidum perforation, and many more. We all know that endoscopic view provides panoramic view, so it allows visualization of the corner as compared to straight view by the endoscope or naked eye. Therefore, it provides a better visualization. So if you can see better, you can do better. This is my concept, and this is possible in most cases. But there are limitations. The limitations are that there is a blind area, which I'll discuss what are the problems associated with this, and how to overcome those limitations. Blind area, difficulty in controlling bleeding, especially when there is a brisk bleeding, and when there is a brisk bleeding, it tends to soil the endoscopic tip because you have a very small focal length. There is a difficulty in bimanual dissection because there is a limited space and because there are prefixed channel. So you can pass instrument through the working channel only in a desired direction. Bimanual dissection becomes difficult in such cases. There may be poor visualization. There are causes, although it provides better visualization, but there are many conditions which give rise to poor visualization in endoscopic surgery, which we'll discuss, and how to overcome those also we'll discuss. Endoscopic surgery requires both the skills. So you need to know the different set of skill which are different from microscopic technique, which I'll also discuss. These are just opposite to the microscopic surgery. So if you are a good microscopic surgeon, that doesn't mean that you can become a good endoscopic surgeon. So you need to know those, and there is a 2D image, there is a steep learning curve. So all these things we need to overcome to become a good endoscopic surgeon. And this is what I'll be discussing today. So we take the first limitation, that is endoscopic blind area, blind spot. So what is endoscopic blind spot? This is inability to visualize the pathway between the skin and the endoscopic tip. So this is an endoscope, and this is the tip of the endoscope. So you can only visualize things which are beyond the endoscopic tip in the endoscopic surgery. Anything which is proximal to the endoscopic tip to the skin is not visualized. So if you, by the way, if you are passing an instrument by the side of the endoscope, you don't know what are there in the pathway, and if there are some important vessels or now or some important structures, they may get damaged. So to avoid that, what should we do? So we should remove endoscope with each insertion of the instrument. If you want to introduce instrument in transnasal surgery or other keyhole surgery, then with each introduction of the instrument, you should remove the endoscope. Therefore, if somebody is holding a scope for you, or you hold a scope for yourself, it is better. And keep instrument about 1 centimeter ahead of endoscopic tip. So you remove both of them. You remove endoscope and keep the instrument about 1 centimeter ahead of the tip of the endoscope, so that you introduce instrument under the endoscopic visualization. Introduce instrument under the direct naked eye visualization till it appears on the monitor. Intermittently look at the monitor. So by the way, if you use telescope holder, supposing you are not using a freehand endoscopic surgery and you are using a telescope holder, in that case, if you introduce instrument, then you have to visualize this area by the naked eye. So until it appears beyond the lens tip, you should make sure that your instrument which you are introducing is not causing damage to the surrounding tissue. That may be anything, and sometimes it may be very important structures. So, and the other way is that you pass instrument through the working channel. So if there is a working channel, if you pass instrument through the working channel, there is no risk of damage because there is already prescribed channel. Or you pass, there is a tubular retractor through which you are passing the instrument. So these two things, if there is a channel, working channel or tubular retractor, that prevents any chance of damage to the surrounding structures, and that therefore it is quite helpful. The other limitations is that there may be brain injury during introduction of the instrument when the scope is close to the target area. This is the example. Supposing you are doing a ETV, this is the floor of third ventricle, and if your endoscopic tip is very close to the floor of third ventricle, and you pass instrument, any of the ventriculostomy forceps or catheter or bipolar forceps, so suddenly if your lens tip is very close to the floor, then suddenly the instrument will appear and you may cause damage to the target area or the floor or whatever tissue is there. So therefore, whenever you introduce any instrument, you withdraw your telescope away from the area. So you withdraw it about 1 to 2 centimeters away, so that when you pass instrument, you visualize instrument much earlier, and then the chances of injuring that floor can be prevented. There may be injury by the linear movement when you are unable to reach to the area. For example, or there are two different target area. Supposing you are doing a ETV, this is a working channel, you have passed the ventriculostomy forceps or Fogarty catheter, and this is not reaching at the area, the translucent place at the floor of third ventricle. So one has a tendency, if you don't reach at the desired object, then you tend to move it either anteriorly or posteriorly, wherever you want to make the perforation. But that should not be done. If you go for linear movement, then the things which are proximal to the lens tip, that is fornix, will not be visualized, and then you can injure the fornix. So avoid linear movement. So what do? So if you are not able to reach to the desired area, then you can rotate your endoscope to the right or to the left or 180 degree to reach at the desired area. So rather than going for linear movement, it is better to go for rotation. There are situations when you have two target areas, like if there is a posterior third ventricle tumor and there is a hydrocephalus, so you want to do ETV and you want to also take the biopsy. So in such case, when you want to work anteriorly, then bring the working channel anteriorly. If you want to take biopsy, then rotate the working channel posteriorly and take the biopsy. So you can go for rotation, avoid linear movement, or a slow linear movement which is permissible can be done. So avoid linear movement because you don't know what is happening to the structures proximal to that area. The other endoscopic blind spot is if there is a straight arrangement. This is the endoscope, this is the instrument, and this is a surgical target area. So if there is a linear movement, a linear arrangement of endoscope, the instruments, and the surgical target area, then the surgical target area will not be seen because the instrument is coming in between the endoscope and the target area. So one should try and make the triangular arrangement. This is the endoscope. So, so position your endoscope in such a way that the endoscope, the surgical target, and the instruments, are in a triangular arrangement. So make arrangement like this. In that case, you will be able to see the target area. You can also visualize the instrument being passed and coming towards the target area. The another limitation, the blind area is introduction of bipolar or the hemostatic agent or the patties in between the endoscopic tick and the target area, that is the bleeding point. So supposing this is the bleeding point, there is a bleeding occurring from here, you have an endoscope here. The moment you bring in the hemostatic agent or the patties or the instrument here, then your bleeding area will not be seen. So if you don't see bleeding point, then you will not be able to, you will not be able to properly place the patties or the hemostatic agent at the area desired place. This is the example. This is the endoscope. If you want to bring hemostatic agent, then if you bring it and you bring in between the bleeding point and the endoscope, then the bleeding point will not be seen. I'll show it in the video also. So what is the correct way? That you bring the hemostatic agent from the side, and then from the side, and then you move it towards the bleeding point and put it exactly at the place where it is bleeding. So I'll show it in the video also. And there may be the blind area at the floor when you pull the tissue towards the endoscopic tip. So supposing this is the tumor, and you want to remove this tumor, and you just pull it towards the endoscopic tip. So if you pull it, then the vessel or nerve in the floor of this lesion will not be visualized. So this is a blind area if you pull it towards the endoscopic tip. Whereas if you move it to the side, cranially, caudally, or to the left or right or medial lateral, then you can visualize what is underneath this, and accordingly you can operate and do surgery. So some of the practical examples of straight arrangement versus triangular arrangement. So this happens when you use Carrison punch in the endoscopic surgery. So this is the example. This is the endoscope. This is the lamina. This is the Carrison punch. This is the biting part of the Carrison punch. This is the foot portion of the Carrison punch. So if the endoscope and the foot of the Carrison punch and the biting part of the Carrison punch are in a straight line, then you don't see the biting part of the Carrison punch, and also you don't see the lamina, where exactly the Carrison punch foot has gone underneath. So if there is a straight arrangement, then you don't visualize anything. But if you keep it at 90 degree, then you will be visualizing the foot and the biting part, and then you rotate it. This again I'll be showing in the video. So this is the cut is a location of the endoscope. This is a simulation model where the ice cream stick has been used as a lamina. So if you keep Carrison punch rotated at 90 degree, then you can visualize the foot and the biting part and the lamina very well, because this portion and the lamina seen very well. And then you know that it has gone just underneath the so-called lamina, that is the ice cream stick, and then you can rotate it and take the bite and take it out. So this is the correct way of doing. Keep it like this and then rotate. Whereas if you take the Carrison punch, where the foot and the biting part are in the straight line with the endoscope, then you don't see the biting portion where it is going. So that is the wrong way. Again, when you use forceps, two-limb forceps, the biopsy forceps or pituitary forceps or anything. So if there is this is the endoscope, this is one limb of the forceps, this is another limb of the forceps, this is the surgical area of interest which we want to dissect or take it out. So the distal limb of the Carrison of the forceps will not be visualized, neither the surgical target area will be visualized. Whereas if you rotate the limb jaw of the forceps at right angle, then you can visualize both the jaws, and in between the jaw you can also visualize the target, surgical target area. So this is the example. This is the endoscope tip, which is visualized by the this cut, and then these are the limb of the forceps which are very well seen, and this is the simulation for any tissue. So you can see that the tissue has been grasped by the forceps. Whereas if you keep both the limbs, the telescope, the one limb of the forceps, the another limb in the straight line, so that limb will not be visualized, and neither you can see that seed which you want to remove for practice hands-on. So these are some of the example. The other example, practical senior scene, which we always see, and the example of straight versus triangular arrangement, how to bring in instrument or the patties or the hemostatic agent when something is bleeding, or you want to, or if there is any ooze. So this is the telescope tip shown by the cut. This is the bleeding point, just a simulation. And if you bring in some, if you bring patties in between the telescope tip and the bleeding point as shown here, then the bleeding point will not be visualized at all. So you are not sure where you are putting the patties. It will be difficult to do surgery. Whereas on the other hand, if you bring the patties from the side, which I have discussed, this is the endoscope tip, this is the bleeding point. So bring the patties from the side and then you bring it towards the bleeding point, and you can put it exactly at a place where you want to do the hemostasis or put things. So these are some of the teaching exercise of endoscopy, just the simulations. Again, same thing, the straight arrangement of the Carrison punch versus, so if it is the straight arrangement, endoscopic tip, the foot and the Carrison punch, not visualized in the beginning, but now it is seen well, and then you can rotate and take the bite. So avoid straight arrangement of the Carrison punch foot and the biting portion of the Carrison or the lamina. And then when you want to take the bite and bring the lamina, tissue back, then again you rotate it back. The another same example, the endoscopic tip and the forceps, the tissue you want to remove, the forceps should be placed in such a way that you can see both the limbs. Whereas if you keep it other way, then you don't see the forceps distal limb. The another example is that the bleeding point, the endoscope and the bleeding point. So if you bring in the patties in between the endoscope and the bleeding point as shown here, then you don't know where you are going. Whereas if you bring it from the side, then you can exactly reach at the place where there is a oozing or the bleeding point. And same thing, don't bring it some, when you want to remove some tissue, don't bring it towards the endoscopic tip. Otherwise, you don't see what is happening at the floor, or any vessel may be there, the nerve may be there. It is not exactly the same example, but just want to show you that if you bring it in between the structures and this, then you don't see the floor. Whereas if you dissect it cranially, caudally, then things can be visualized. So I have already said that you try to make a triangular arrangement, but it is not always possible. What do you do when you cannot avoid the straight arrangements? So there are situations, and I came across these situations when the straight arrangement could not be avoided. For example, there is a partial corpectomy. I do decompression when there are multiple level compression, and the compression is against the vertebral body. So in that case, you have to remove the part of the vertebral body. So we do partial corpectomy. So only about 3 to 8 millimeter of the vertebral body is removed. This is the disc, cranial disc. This is the caudal disc. This is the vertebral body. So only part of the vertebral body has been removed, and the vertebral body on the left and the right has been left, and therefore you don't require any grafting. So, and this is the tubular retractor which anybody uses in endoscopic surgery. So you have only these two options. Option one, where you can put in endoscope, or option two, so you can put endoscope either cranially or caudally to visualize the depth in the surgery towards the dural thecal sac or the osteophyte or compressive force. So only two position. If you want to keep endoscope here at 3 or 4 position, because of the intervening vertebral body, you will not be able to visualize the depth towards the thecal sac. So you have the endoscope here. You have to put in a drill and a suction, because there may be oozing continuously. So one suction and a drill. So if you keep the straight arrangement and you put in a drill here, then the distal instrument will not be visualized. So that was the limitation which we found. So we found the answer. Unfortunately, there was no technique described how to avoid blind area when you are working in a straight line. So what I did, and I describe it, which I'll discuss in the second slide. You see that in partial corpectomy, only the part of the vertebral body, 2 vertebral body and 3 discs have been removed partially, and the decompression can be done. The posteriorly you can angulate it more. So anterior part of the vertebral body is seen, but the posteriorly the vertebral body is not visualized. So you can go for a good decompression, and the fusion is not required because only about 1/3 or even less than 1/3 of the vertebral body has been removed. So this is the endoscope. If you put in suction here, then you cannot put in drill, because the visualization of the distal part is, will not be there. It is a blind area. So what we described is that you put in distal instrument first. So put suction first distally. This is the endoscope. Put the suction distally. Keep the suction at a desired depth to suck the blood which is oozing, and then you use the drill. The drill, you can visualize things. So osteophyte you can drill. Keep the suction at a desired depth to keep on sucking. And you can know indirectly that you are at a desired depth or not. If you find that there is a pooling of the blood, that means your suction has been withdrawn little bit. So go a little bit down, and when there is no more blood, that means you are at a correct depth. But if you go a little more deep, then there may be movement of the dura. So that means you are going more deeper. So you have to be careful. Don't go deeper. If you come out a little bit, then you will know, because there will be pooling of the blood. So this is what we have described, that put in the distal instrument first under vision, keep at that particular depth, and then put the drill in between, and you can keep working. Although the ideal situation would be that you put in endoscope in the middle, but there is no endoscopic set available in the world which can allow endoscopic, the endoscope to be stationed at the middle of the tubular retractor. The commercially available endoscopic site. So if somebody can make the arrangement in which the scope can be placed centrally, then you can pass in drill from one side and the suction from the other side. So because of these non-availability, we were forced to think of surgical nuances, and then we published this, the surgical nuances to avoid blind area in the endoscopic surgery, that is putting in the instrument distal and then going in for surgery drilling. The another disadvantage of endoscopic surgery is difficulty in control of bleeding. For example, if you are doing a ETV and you use Fogarty or ventriculostomy forceps and it bleeds from the margin, then you should either reinflate the Fogarty or put in the ventriculostomy forceps at the bleeding point, or you put the sheath at the bleeding point so that it stops, the bleeding stops, that oozing. Rather than taking out the Fogarty catheter or the ventriculostomy forceps out from the working channel, and then you try to bring in the bipolar. By the time you bring in bipolar, there will be a lot of, there will be bleeding, and then you will not be able to see anything. So these are some of the methods. Block the outflow channel for short duration so that there is a tamponade effect and you can watch the bleeding point, and if required, you can coagulate them later on. If there is a bleeding, you should stay in the field, keep irrigating. Don't remove the sheath, because once you remove the sheath and if there is a oozing, you will not be able to see anything, and then putting the sheath back will be very difficult, rather impossible. So keep the sheath there. You can remove the endoscope if you want. If it is a soiled, you can withdraw a little bit. You can come in the lateral ventricle and keep irrigating, but don't remove the sheath. The other point to stop bleeding or visualize is to convert the large space into the small space. If there is a bleeding in the ventricle, which is a large space, so blood in the ventricle, you don't see anything. So what you should do is that you withdraw your endoscope a little bit, maybe 1 centimeter or 1.5 to 2 centimeter away from the sheath, and then you create this large cavity into the small cavity. So because of the clear fluid from the irrigation channel, you will be able to visualize the bleeding point, and then you can keep the sheath on the bleeding point and coagulate it. So create a large cavity into a small cavity and introduce the clear fluid through the working channel, and you can visualize the bleeding point and control this bleeding. If these things do not work, then you can convert dry field technique. So remove the fluid and replace it with the air. If there is a air, then the visualization of the bleeding point becomes very easy. So you can see the bleeding point, and obviously you can cauterize it in the air media. So if nothing works, then you convert the liquid media into the dry field, that is air media. And even if these things do not work, then you can use tubular retractor or port system, which works with the air media. So there is a air media, so you can see the bleeding point, and then you can coagulate it also. So these are some of the strategies if there is a bleeding in the endoscopic surgery. The another limitation of endoscopic surgery is difficulty in instrument handling. That is, movement of the instrument in a narrow area. And the most important cause of the hindrance is the telescope itself. The telescope is placed in a limited area, so the telescope may not allow the instrument manipulation very well, and this happens when the endoscope is too close to the surgical target area. This is the example. This is the field. This is the endoscope. This is the area where you want to work. So if the endoscope is very close to the target area and you want to introduce instrument, this telescope is coming in your way. So the best thing is, so if it is very close to the surgical target area, or if it is in the center of the field, then it may cause obstruction. So what is the best way? You keep the endoscope at the corner so that it does not cause any hindrance in the instrument manipulation. Two instrument you can pass, and you keep it as much away as possible. But you cannot keep it at indefinite place, because there is focal length beyond which the tissue will not be seen. So usually the focal length is about 2 centimeter of the smaller size endoscope, that is 4 millimeter or 2 millimeter endoscope. The focal length is about 2 millimeter, 2 centimeter. So you can place it as much away, about 2 centimeter away from the depth, and place it at the corner so that you can visualize things and you can pass to instrument and go for bimanual dissection. There is a sword effect that should be avoided. And what is that sword effect? The direction of the scope, the direction of the instrument, and the target area are in the opposite direction. This is the surgical target area, which is there on the left side, but the tubular retractor is directing on the right side. So it is on the opposite side. The endoscope is also directed on the opposite side. So if the endoscope is also like this, the instrument has to go towards the target area. So there will be crossing of these endoscope and the instrument. So this is known as sword-like effect. And if there is this type of effect, then the instrument manipulation will be difficult. So the correct way is that you station your endoscope at the corner as much away as possible, and you direct it in the direction of the surgical target area, so that there is no crossing of the endoscope with the instrument. This is also correct. If you are working quarterly in this direction on the right side, then place endoscope on the right side, and the instrument also will be going in that direction. Sorry. So another causes of difficulty in handling of instrument in the limited space, the keyhole surgery, when you use thick instrument and the straight instrument. This is the example. See, there is an endoscope and these are two instruments, and there is a keyhole surgery, limited space. So if you use thick instrument, then the whole space will be occupied by the telescope and the instrument, and you will not be able to do bimanual dissection. No movement is possible, so surgery will be difficult. Whereas if you pass the slender instrument and single limb instrument, then there is a sufficient space for the two instrument to manipulate. There may be difficulty in reaching the target at the corner of the target. See, this is the surgical target, this is the endoscope, and this is the instrument. If you bring in instrument, then the tip of the instrument, the endoscope is blocking the instrument to reach at the corner of the surgical target area. So, withdraw it a little bit and use angle tip instrument. So use angle tip instrument and place the endoscope at the corner as much away as possible. Then you can reach at the corner. So these are three maneuver which one can do. One is the withdraw the scope so that the instrument, you allow some space for the instrument to pass. Second is you use angle tip instrument so that in the limited space, the angle tip can reach at the corner. And if nothing works, then what you should do is that you withdraw the endoscope first. You withdraw it even furthermore. Bring in your instrument and take it to the desired side, and then gradually introduce your endoscope in the area wherever you can introduce it. So this is the last resort that one can do when you are not able to reach at the margin when you are doing endoscopic surgery. And if there are, if there is sometime there's a oozing, you need bipolar coagulation, you need suction, and there's already limited space. So one should use two-in-one function. One can use suction and the coagulation in one. So suction and coagulation in one, so that in the limited space, you can do both suction and coagulation. The causes of poor visualization could be because of the humidity in the air media, could be when there's a blood on the tip, or there's a bone dust on the tip, or the drop of the fluid, or there is a lens staining because of the brain tissue or any other tissue. So if these are there, treat the cause. If it is a humidity of the air, then just by sucking the air in the cavity, you will find that the visualization becomes good. If there's a blood or bone dust, then or you can use anti-fogging agent. There are commercially available lens cleaner. If there is a swelling of the lens, then you can use those lens cleaner, or you manually irrigate with the saline and suck the lens tip with the suction. So the telescope will become clear. If there is a bone dust staining, then you should keep the endoscope as much away as possible. If you do a normal routine surgery in the endoscopic surgery, that means you keep on drilling and irrigating, and the endoscope is there, tip is there at very close to that bone. So there will be frequent soiling of the lens tip by the bone dust. So what you should do, keep the endoscope as much away as possible, and then use intermittent irrigation between the drilling. So don't do simultaneously irrigation and drilling. So do a short duration drilling and then irrigate it so that there is no heat generation, and then do drilling and irrigation in between. Place some tissue, that is silicone tube, between the scope and the brain tissue so that there is no lens swelling. And because to avoid these things, we have used tubular retractor or modified retractor, which we'll discuss. There may be improper connection from the scope to the monitor, or there may be damaged endoscope. So in that case, corrective measures should be done, and the visualization will become good. The other cause of poor visualization is telescope out of the focus. So do proper focus of the telescope using proper button. There may be unwanted tissue in between, in front of the telescope lens. So remove that tissue or move the endoscope to the side so that you can see things. Another very important point is when there is a bleeding in, for example, in endoscopic surgery, if there is a bleeding, and then if you, this is a working channel, this is a blood in the third ventricle, this is the channel This is the catheter. So if you keep catheter in the working channel and keep sucking, then the blood will come towards the lens and it will be further soiled. So you will not be able to see anything. So what should be done? That the catheter should be beyond the lens tip. So place the catheter tip beyond the lens tip, and then you suck it. In that case, you can visualize things and still work. So don't place the catheter in the channel and keep sucking when there is a bleeding. Scope in the wrong direction. This is the surgical target area, this is the endoscope. So you can see it well if it is directing towards the target area. But if the target area is on the right side, but your endoscope is tilted on the left side, then there may be poor visualization of the surgical target area. That also must be known and you should correct it. Limitation 2D is the most important limitation of the endoscopic surgery. Now 3D endoscopes are also coming, but these are also, so far they are not so good. But I think in future 3D endoscope of good quality will come. And this difficulty can be overcome by the dynamic movement of the scope and the instrument. So if you keep the endoscope and the instrument at a definite, say about 1 centimeter ahead, the instrument is about 1 centimeter ahead of the lens tip, then you can introduce it, and usually there is no problem in reaching at a target area, because there is a dynamic movement of the instrument and also of the telescope. So both things are in the focal length. So there is no problem when you move both of them together. But otherwise also I did not find any problem in using endoscope. So supposing this is the endoscope and I want to bring in instrument. So after the endoscope tip is visual, then you can make out the depth of the instrument tip by knowing the surrounding structures. So also visualize the surrounding structures and make little oblique movement. So by doing those oblique movement rather than going straight and using an angle tip instrument, that the disadvantage of 2D, 3D, I have not come across. There may be difficulty in orientation. The camera may rotate. The camera should be placed in the correct position. The orientation should be checked by anterior, posterior, or side movement. The camera head, usually the button should be towards the monitor. The image should be seen as it is seen in the open surgery. That when you do surgery, you can realize the camera can rotate during surgery, so you can keep seeing that if it rotates, then the whole orientation will go in a wrong way. So you may cause problems. So keep watching the camera position. It may be difficult to identify the anatomy when you use very high magnification. So to have the orientation, you de-zoom, and then you can find out the structures rather than having a zoomed view. So only a part of the structure will be seen, and there may be problem in identification. So in a vague way, if you can see the whole, I mean, every structure, face, eyes, and teeth, lips, everything. So in that case, you can identify a person, but just by looking at the eyes, it may be difficult. So de-zoom it and have the overview, and then you can identify the structures. You should have a proper knowledge of anatomy. If there is a disorientation, use neuronavigation. So learning endoscopy, I told you that you require 2 skills. You require microscopic skill And you also need to require endoscopic skill, which may be completely different. So these are the example in the microscope and in the endoscope. Usually the instrument used in the microscopes are bayonet shape, whereas in the endoscope you should use straight instrument because the rotations are easy. So don't use bayonet shape instrument when you are doing endoscopic surgery. Usually we usually center our field of interest in the center in the microscope, whereas it should be at the corner. The area of interest, you make it at the corner, because if you make it at the center, then your endoscope has to be in the center of the field, and that endoscope will be obstructing the instrument manipulation. So it is better to place the endoscope at the corner and visualize the target area at the corner rather than at the center. There's a blind area in the endoscope which is not there in the microscope. There may be change of orientation in the endoscope which does not happen in the microscope. The drilling is easy in the microscope because the scope lens is far away. It may be difficult. So go for intermittent irrigation and drilling. The instrument manipulation also is difficult in the endoscope because whatever limited space is there, the endoscope occupies some space. So you have to manipulate, place the endoscope at a correct position, and to know how to manipulate instruments to instrument in that limited area, that you have to learn, and then only you can perform endoscopic surgery. The control of bleeding in the microscope is easy, may not be so easy in the endoscope. So you have to learn that, and there may be 2D and 3D things. So in the endoscope, you have a steep learning curve. So transition may be difficult, and these are because of difficulty in controlling bleeding, blind area, the unique skill which you have to acquire, 2D image, limited space orientation, and more operating time. So these are the problems which prevents a surgeon from adapting endoscope from microscope. So proper training is required. Usually you should go for simple case in the beginning and then take complex cases. Multidisciplinary approach, you can take help of ENT colleague or orthopedic colleague if they are expert in that field. Practice on model, cadaveric dissection, live operative workshop, lab training and simulations. So you can use various training models. For deep-seated training, you can have a simple training model by using, you can work through a narrow tube in the endoscope and do surgery which we have devised. You can practice on superficial operating area. You can practice suturing on surgical gloves or the tube, dissection on papaya or capsicum, hemostasis can be practiced, cutting on surgical gloves, and you should practice on high magnification. So because the training models were very costly, so we devised, Dr. Jitin Bajaj has done tremendous work, and he devised this the indigenous inexpensive model. So these this does not cost anything. The earthen pot, there is a hole made in it, so you can work through it, and you can place the ring from one place to another without touching the pins. So hand-eye coordination can be learned by simple method. So place this this thing at the bottom of this pot and then practice it. And then you can have ice cream stick which is stuck on this foam, and then at a desired place you practice how to do the laminectomy. And also at a desired place on the gloves, you can use scissors to cut. So you can practice various endoscopic technique of cutting using scissors and hand-eye coordination and even hemostatic model. But still using all these things, there may be problem in endoscopic surgery. In channel endoscopic surgery, that is ETV or intraventricular surgery, although it is pure endoscopic surgery, the instruments are passed through the working channel. There's a difficulty in manipulation of the two instruments because you have to pass it through the channel which are predetermined. So bimanual dissection is difficult. It is under liquid media. So if there's any bleeding, it is difficult to see. So therefore, it is indicated only for small and avascular lesions. Whereas if you use tubular retractor, so take help of, so you can use endoscope and you can use tubular retractor to overcome some of the limitations of endoscopic surgery, and you can do most of the surgery if you combine endoscope with the tubular retractor. This is the example. I think for the want of time, I don't say the endoscope. Tubular retractor was used. You see, there was a large tumor, and with the help of endoscope and tubular retractor, we could remove this lesion totally. We have overcome some of the limitations of channel endoscopic surgery by using the port system. So bimanual dissection, see, the two instruments are passed very well. You can go for very easy bimanual dissection. In the endoscopic surgery, you can dissect the tumor the way you want as you do in the microscope. So I'll not go through the whole video. The idea is that the limitations of channel endoscopic surgery can be overcome with the help of endoscope and the tubular retractor. We devised the tubular retractor, which has many advantages, which all of you know. And there are some difficulty in chronic subdural hematoma. We came across the working in a curved cavity. The chronic subdural hematoma is not a straight cavity in which you can pass the endoscope and take out the hematoma. It is a curved cavity. So there's a difficulty in reaching the full length of the cavity using a rigid endoscope. And if you use flexible endoscope, the quality of image is poor and surgery takes time. So there's a lot of problem. But you can use rigid endoscope and take help of something else that is modified retractor, and you can reach the whole length of the cavity. There are sometimes very small cavity, so it is difficult to put in the endoscope in that small cavity, and to pass two instruments simultaneously in the cavity becomes difficult. So we found this difficulty in some cases, especially young patient with a small cavity, and when there's a large cavity extending from frontal region to posterior to the occipital region. So in that case, we use this modified retractor, which retracts the inner membrane, and you can reach up to the posteriormost limit and take out the hematoma totally. So visualization of the distal hematoma can be done. The small width of the hematoma, and at times there is a sudden expansion of the rapid expansion of the cavity. When you remove half of the hematoma, the brain bulges, so cavity becomes very small. So it is difficult to put in the endoscope and the two instruments. So if you use this soft tubular modified retractor, this retracts brain and allows you to work, and it prevents swelling and so many advantages. So you can take help of retractor I think again, I skipped this. This was hematoma extending from anterior to posterior side. So initially did some suction of the hematoma, the coagulation of breathing vessels. You should see the breathing vessels and coagulate and cut. And after that, you put this modified retractor because it is difficult to reach at the most posterior portion. So to go for a little bit of retraction of that part, you can use this soft tube, which allows the dynamic retraction of the inner membrane, and the full hematoma can be evacuated. So the message for young neurosurgeon is that young neurosurgeon should choose a new specialty to have early recognition. So you should not do just a simple general neurosurgery. You choose something new, and I think endoscopy is not bad because endoscopy neurosurgery has a good future. Most of the surgery will be performed with either alone or with the help of endoscope in future. Therefore, all neurosurgeon, young neurosurgeon at least, should learn how to do neuroendoscopy. And how you should choose a subspecialty, which subspecialty you should go, you should give a good thinking. It should be unique. Not many people should be doing. Interesting for you, possible in a local setup. There should be good demand, affordable, and you should be expert in that field. Otherwise, you will not be able to do it. And should be a mentor available or training center, and the clinical outcome should be better than the conventional microscopy. If the answer is yes, then you can further learn by expert or visit the centers and go for live, attend live operative workshop or cadaveric workshop, invite expert to your place, watch operative videos, start from the simple case and then progress to the difficult case and take help of seniors or mentors. And this is how you can succeed. We have published this, how you should choose, and you can read this article in Indian Journal of Surgery, so how to choose that specialty. So to conclude, there are advantages and there are limitations of endoscopic surgery. The surgeon should learn to overcome those limitations. We usually tend to look at the advantage, but we don't see the limitations. So always look at the limitations of endoscopy and overcome those limitations. It is not difficult. Nothing is impossible. Difficulties should be taken as opportunity, and this helps in innovations. And we use this thing because we worked in deficiencies, and therefore, when things were not available, we devised the surgical nuances to avoid the blind area. That is, put the instrument distally, and then we devised tubular retractor, which is possibly the best one, and a modified retractor from chronic subdural hematoma, and inexpensive model for practice in endoscopic surgery, and so many new techniques endoscopically we have given for the first time, including single stage anti-decompression and fusion using transcervical approach, corpectomy, and many more. So for the want of time, I thank you all, and I thank my teachers and colleagues for all the help. Thank you very much. Sorry, I think we took more time.
No, I think there was some interruption because something else crept in. So not exactly yours.
Yeah, I'm sorry about that.
Yeah, somebody had hacked up.
No problem, no problem.
So
But
that was
overall, very nice presentation, sir. You have summed up all the nuances in the neuroendoscopy. And I remember last time somebody asked like how to prevent a complication and how to be gentle. So this is the apt, I think, webinar, and each line solve a lot of problems. And I think all the generation of neuroendoscopic surgeons from, I think, young one who is just getting into the neuroendoscopy to expert guys. This, like all the nuances that you shared are complete and very guiding force. So thank you very much for this good lecture, sir.
Thank you.
sir. Thank you. Thank you. You
Excellent.
covered each and every aspect, how to hold endoscope, how to avoid the flight area, and especially when two instruments are fighting each other, and how exactly the skilled sportsman uses his crafts and then gets into, and then how exactly avoid the do the depth perception, how to make a 2D into 3D type. So it was definitely a masterclass for almost all learning people, sir. So as of now, I don't see any questions over here.
And so what
So I invite comments from Dr. Jitin Bajaj, who has invented a lot of in situ model for training and inexpensive models. He has represented us in our college in US, in CNN, as well as in AANS workshops. Dr. Jitin, please, your comments.
Thank you, sir. It was an excellent lecture, sir. Sir, to me, all of these techniques, the best technique is to see and assist a master neurosurgeon like Yadav sir. And as much as we see him and assist him, we learn new things every day. So that's my message to younger colleagues, that go and see master neurosurgeons, how they do simple as well as complex cases. And sir is doing regular fellowship programs. So each one is invited to visit and see this. Thank you.
We also found the animal models very important for learning. Before going on to the human thing, as Sir said, that doing microscopic surgery is the background. After that, to simpler endoscopic surgery, and then on to the complex. So, like that, Dr. Jitin used sheep and the goat model, for that, and then that really helped us, neuroendoscopic people. Dr. Dutta, you have been a person who trained from this neuroendoscopy fellowship, and after that, you have spread that in the whole of All India Institute of Medical Science. Your comments, please.
Yeah, exactly. What have been told by Jitin, like I was telling since long time. One of the, every aspect is important when you are a beginner, like knowing instrument, how to handle it. Like as sir's lecture started with the blind spot, when you like traditionally you get trained for like endonasal and only for the ETV. When you progress in your career and you see that you want to go with the transcranial one, and then you realize like, okay, your endoscope is stationed inside the cranium, and then you have to put other instrument inside. Then this kind of principles, these blind principles, how to maneuver around, how not to damage this, that comes into the picture. So I'm to say, like from basic things to the advanced work, all those points are important. And one prime point is like, yes, if you have a surgeon, if you are a mentor who is doing that work, watching him, assisting him is one of the most important things. And being there like since long time, I think 1 decade, I can say that in Jabalpur with Dr. Yadav sir, and every time I learn. So the one of the more impetus for coming there is like I learn every time. Every time I correct certain thing, and this is kind of say Gita, like it's so big things, and every point to understand and put into the practice, it requires like more and more your practice starts, or you go into the complex things, you'll realize the importance of each line. So that's my
Dr. Ratre has been, Dr. Ratre has been his shadow, and then he's making the master do a master surgery. So the difficulties, what he has learned, and then what he has, he doesn't even let us know that there was a difficulty. So his comments, please.
Thank you, sir. So it was a very nice lecture, sir. And this was a not lecture of the sir. It was the journey which sir has done since last so many years. And I have assisted sir, and I have seen that sir has find some difficulty in a case, and in the next case, sir was ready with the solution. So, sir always said, as you learn from the difficulties and you always search for solution. So don't repeat that mistake in the next surgery. So keep learning, and the best way is to learn from the lectures, from the videos of the master neurosurgeons like Yadav sir. And these are the very basic points. And sir has covered all the points, and we will not find these points in any textbook. So these are the very basic points, and young neurosurgeons always find this difficulty, and if they not get the solution, they don't get interested in the endoscopy. So these are very important tricks and very helpful.
Yeah, I agree. The steep learning curve, if you work with the master, it becomes, child's play type, and then you learn it very fast. Dr. Harshad Parikh has got a comment. Please, sir.
Good evening, Dr.
Good evening.
Yadav.
Sir, good evening, sir.
Excellent presentation, and master's voice is saying about the pearls of wisdom for the endoscopy. And it shows your journey and hard work, a number of cases you have gone through, and so many doctors have been trained under you by your workshop, by your visits, and you conducting workshop different places. It's a beautiful tool to use, and I've been going and attending webinars and lectures at many places, and seen many surgeons are only doing endoscopic surgery, no microscopic. And I still remember a couple of months back, we had a Japanese neurosurgeon coming and operating everything endoscopically. Whether you say petroclival meningioma, whether you say cyst, whether you say hematoma or anything, a transorbital approach endoscopically. So endoscope has come in long way and big way. And there is a big learning curve, no doubt about it. Everybody cannot do it in every case. And as you rightly taught us, you start with a simple cases and start learning. It's matter of using more and more, going to laboratory and doing more and more cases. As other doctors also saying, every time you learn and you correct next time. So this is whatever indications you have seen, I still feel there is a much more to extend to the indications of this, what I have seen. And the other day, a trigeminal schwannoma I have seen endoscopically being done, which was coming from the cavernous sinus into the posterior fossa, and whole thing was endoscopically done. And I was surprised to see that American doctors were doing. So things are going in a very refined and very specialized way. And we need to learn everything. There is no question about it. We cannot avoid, okay, we'll not do this, and we'll start criticizing, okay, no, microscope is better and all. It's very good to learn, and you are inspiring everyone to do more and more. Wonderful job you are doing, and your own experience will help everybody. I saw first endoscopic surgery. You will not believe, in 1986, when in JJ Hospital, Dr. Virani did first endoscopy, and I was a resident that time, 1986. And he got in this instrument and toy, and we were so excited. And then he presented the same thing in Trivandrum, and a lot of criticisms came. How can you use this? And in that meeting, I was just doing my MC at that time. And we never realized that this can go on like to such an extent. And that time we were using either ETV or some cyst or limited things we were learning. Everybody was learning how to use the endoscope. And this is how it has progressed, and this is a journey which has taken ahead. And I'm sure it will go further and further. Only one point I was thinking of, suppose an exoscope comes in existence in a regular way. Now it is at a very limited. Do you think that exoscope will replace the endoscope?
Sir, exoscope can be used for learning endoscopic surgery. Basically, exoscope is a microscope. There is hardly any difference between exoscope and a microscope. You place exoscope outside the operative area, So the visualization at the corner, which is the main advantage of endoscope, is gone. So it should be used as a learning tool for endoscopic surgery. And a lot of things can be done with the exoscope, but the proper advantage of endoscope, that is seeing at the corner, is not there in the exoscopic surgery. So one should use it for learning, and it is a good tool. Most of the things can be done. People can use, I mean, they are doing most of the things with the microscope. Unfortunately, what I have seen, what I am more depressed is that the younger neurosurgeons are not opting for this thing. And unfortunate aspect is that I have been seeing in the most of the conferences that the senior neurosurgeons say that it is useless. Endoscope doesn't help. When you can see well, you can do it well. The problem is that you are not able to learn the skills, how to manipulate the instrument around the endoscope, how to place the endoscope and do bimanual dissection. So as you have said that I was there in the conference, and Dr. Virani in one of the conference, every single neurosurgeon senior said, what are you doing? This is not the way. And there are so many younger neurosurgeons, and you should not talk like this. So if somebody cannot do it, that doesn't mean that the other also cannot do it. And we should all, I mean, what should I say, that we should encourage the newer things to be done. But I don't say that you do more complications. You learn things first. I have told, therefore I said there are limitations. So you have to understand the limitations and how to overcome those limitations. And if you can overcome those limitations, anything which is done by microscope can be done by endoscope. And the future is endoscopic surgery. Therefore, I am requesting all young neurosurgeons, please understand, they just want to see the operative, how it is done and quickly. They don't want to see what are the problems come in the surgery and how to overcome. So this is a basic thing which they should understand. And when use microscope also, there are advantages of microscope, there are advantages of endoscope. So everything which is best for the patient should be done. And at least for younger neurosurgeon, please, you should learn endoscopic surgery. In future is endoscopic surgery. Most of the surgery in future will be done by endoscopic surgery. Sir.
What about the using an robotic arm to hold the endoscope? This Krishna Karad people are, recommending, if they have developed that from the SQLab and they are using it. I don't know how they control the robot's movement when you are operating yourself.
Sir, we don't have, but I think there are advantages. I always say that the advancement is always good. I never had the navigation, the advanced tubular retractor, so many things. So I invented small, simple things. Not having facility doesn't mean that you cannot do it. I can do almost everything with the available instrument, but if you have facilities, these are good. But there are limitations. Those people who have these robots and ROSA, they have limitations. But if you have facilities, yes, use it. And in future, things will improve.
Yes,
things
definitely.
will improve. There are primitive things available. I mean, these surgery will advance in future. Yeah.
Yes. We are learning every Sunday. Every Sunday we are learning about more and more endoscopy.
Sir, thank you, sir.
Yeah,
Thank you.
regarding robotic arm, like we have used ROSA and other arms as well. And the basic arms is like the fixed
Kodai
hand.
is also Dr. Datta is an expert from AIMS, one of the apex institution, and he is expert in endoscopic surgery. After Dr. Datta, I think we will request Dr. Kodai. He is one of the
Yes, sir. Yes.
I mean, young. In the beginning, he came and attended our workshop, and he is doing a lot of good work. Dr.
Yes, sir.
Kodai, yeah, Professor
Yes,
Datta,
sir.
please.
Yeah.
Please.
So, I mean, there is always a scope, like how this endoscope evolved over the years, because some, like from single, this one to this HD, and then now to the 4K, and then 3D. So this advancement will be always there. Similarly, from fixed holder to a mobile holder like Metacam, and then we tried Rosa as well, but the movement was not very controllable for endonasal work. But there is always a scope for further improvement and fluid movement, so that you can navigate, you can just mobilize it like a human thing. It may be not a like an expert assistant, but yes, if you don't have one, they can replace it to help you in doing biomanual research. This was just a comment.
Oh, excellent, excellent.
Yes, sir.
Fascinating.
Actually, yes, sir. Actually, I am following Professor Yadav for more than a decade. So, first point for young neurosurgeons, always you should have one mentor. So, like Yadav sir, it's very difficult to have a person like him because he's down to earth to teach everything. Number two, the problem in learning in endoscopic neurosurgery is a steep learning curve. Each and every procedure will take a steep learning curve, and also the surgeon who is trying to learn have some patience to learn that. That is the main problem for each and everyone. So, for example, if you start doing tubular retractor based surgeries, you should at least work towards that for at least a year to get trained in that. The another problem is cost of the equipments. Each and every procedure needs costly equipments, and also like Professor Yadav, we used to innovate things, and also we used to develop things like tubular retractor. Last time, sir showed one catheter which is having a VP shunt that wire, which can be used as a deeper coagulation probe, but it is expensive, almost 25,000 rupees in any company they are selling. So youngsters should start design like Jitin. I was impressed about Jitin's work. So we should start developing instruments in endoscopic neurosurgery. Like people nowadays, they prefer only minimal invasive procedures. So like sir said, it is almost the future is only endoscopic neurosurgery, and now almost 20-25 indications are as posted, and so slowly this indications also will go up. Another one question to Professor Yadav sir. So you are using that corpectomy for endoscopic procedure. How will you place that tubular retractor, sir, while doing that procedure?
Yeah, that is quite a difficult thing. You have to keep changing it. I told you the surgical nuances to avoid the blind area came from the difficulty I came across doing a partial corpectomy. Because there is a straight line and there is a very narrow corridor. So if you put in endoscope and you put one instrument, the other instrument is not seen. So therefore, I thought of things and then I described that how to avoid things. So you have to place, if you want to work cranially, you place endoscope cranially and then work from below you angulate it cranially. If you want to do, I go for reverse funnel sort of procedure in carpal, in partial corpectomy. The anteriorly, the drilling is small, posteriorly it is more. So you have to angle it for cranial drilling, angulate it cranially, for left side drilling, angulate it on the left side. and place the endoscope on that side and like that. So you have to keep changing the position of the endoscope, and you can achieve that because it allows you visualization at the corner.
Sir, how to place that holder? You use a holder or?
Yeah. I use the EasyGo system that
Okay.
which is marketed by the
Stores.
stores. But unfortunately, I've been telling them that there can be small attachment which you can place. If you just place a holder there in the center and place the endoscope in the center, everything will become simple. The problem with the existing system is that you can place endoscope only
One corner.
at the corner. So most of the
Yes.
surgery can be done with this. But there are situations in which there is a linear, narrow corridor in which you require to place endoscope at the center, and which can be done very easily. Unfortunately, people are not working on them. For them, having some innovations and having a design, it takes some crores. So we are lucky in India that we make some design, still work with that on the patient. So I think in future something will come and we'll have better instruments and better design of things. I have so many ideas, but unfortunately nobody is ready to make them in practical form.
Well, I don't see any further questions, sir, except Dr. Abraham, and he has congratulated you, sir.
Thank you, everyone.
And
Thank you, Abraham, and all viewers and colleague, panelists, seniors, John sir, and obviously my friend Dr. Swami. Thank you. I think John sir, you can end the meeting if everything has been covered.
Yep. Thank you, sir.
thank you,
Thank you,
sir.
sir. Thank you.
Thank you, thank you,
Thank you,
for-
sir.
Thank you.
Thank you, sir. Thank you, everyone.
you,
Good
thank-
night. Good night.
Thank you, John, for hosting this. We'll meet next week. You have to unmute. John, you have to unmute.
I'm sorry, I should know that.
Yeah.
Okay, now next week we have endoscopic interlaminar lumbar discectomy, which I'm looking forward to, another good interactive session. And so we'll see you next week. Thank
Okay.
you.
Thank you. Good
Night.
night.
Have a good day.